Welcome to a relaxed session of learning about orthodontics over a cup of coffee. I'm Ji Dae-kyung, the senior host of Ortho Barista.
I'm Lee Jongkuk, the junior host of Ortho Barista. Continuing from last time, this is our second session on clear aligners. If you have any questions, feel free to leave them in the chat. And we'll select winners to receive Starbucks gift cards.
Today marks the last day of May, and we have a special final event for our Ortho Barista viewers. Those who submit the best questions will receive a toothpaste and toothbrush set from the Vussen X Musiktiger collaboration. Don't hesitate to ask plenty of questions. Let's get started with today's topic, the key criteria for initial success with clear aligners and diagnostic considerations.
Are we diving straight into the main topic today?
I thought you'd ask, so I've prepared a special coffee.
Oh, a special coffee?
Wait. It's served in a paper cup. But last time you had Luwak coffee, right? The color looks pretty similar.
This color does seem familiar.
Try this coffee. Sweet flavor.
Ah, this is it.
Today's coffee is instant mix coffee.
Aren't you having any financial difficulties all of a sudden?
Let's dive into the 7th episode of Ortho Barista, accompanied by mixed coffee. Today is the second session on clear aligners. Building on last time, we're bringing you slightly upgraded content. Our topic today is clear aligners, key criteria for initial success and diagnostic tips. We've been involved with clear aligner treatment for quite some time now. We've analyzed the results and established a few key criteria as we begin to incorporate Magic Align treatment. Today, we'd like to share these insights with you. When starting clear aligner therapy, especially in cases involving molar distalization or significant crowding, there are various solutions to consider. This may include stripping, arch expansion, and other techniques. A key focus in clear aligner is whether it's possible to achieve specific tooth movements, such as molar distalization, effective vertical control, or posterior expansion. If these can be done effectively, do you think the clear aligners are easy or difficult?
I think it isn't about whether clear aligners are easy or difficult.
While challenging, it's certainly doable and worth exploring. Lastly, although not a major topic today, communication with the dental lab is crucial, and we'll touch on this in more detail later. When encountering cases of crowding, as orthodontists, we tend to explore several solutions. What could those be?
As mentioned previously, the positioning of the maxillary central incisors often determines whether treatment will be non-extraction or extraction. If the approach is non-extraction, there are likely three main strategies to consider: expansion, distalization, and stripping.
Yes, that's correct. Typically, when encountering this level of crowding, extraction is often the go-to solution. However, diagnostic perspectives may vary. Today, we want to focus specifically on molar distalization. Let's delve deeper into this topic. In aligner therapy, molar distalization is approached slightly differently compared to bracket-based orthodontics. Typically, movement begins with the number 7 tooth. Once the tooth have moved about halfway, the number 6 tooth starts to move. Similarly, when the 6th tooth have moved halfway, the number 5, number 4, number 3, and number 2 teeth follows the movement in sequence. The halfway concept refers to incremental movements relative to the target distance for molar distalization.
So, how many millimeter do you consider?
Based on literature, the limit for molar distalization is generally considered to be around 3 to 4 millimeters. Keep this in mind as a guideline. Beyond this limit, further movement becomes challenging.
Typically, the number 7 tooth is moved 3 millimeters distally, and once the number 6 tooth has shifted about 1.5 millimeters, the other teeth begin to move gradually as well.
Another critical consideration is the principle of action and reaction, which also applies to clear aligners. As the molars move distally, there is often a reactive force on the anterior region, causing a tendency for it to protrude. To counteract this, elastics or screws can be utilized, and we will provide a brief explanation using a case example. Next, let's discuss vertical control. Typically, when we proceed with bracket-based orthodontics, we use intrusion arch wires or screws to achieve intrusion. Of course, Dr. Jungkook will show a case using screws for intrusion a bit later. For vertical control, take a look at this paper, which discusses mechanical considerations and related factors. In a way, the principles applied in bracket-based orthodontics naturally extend to clear aligners as well. For instance, intruding the anterior teeth in the mandible while extruding the posterior teeth. In textbooks, this is often referred to as relative intrusion. In the later stages of alignment, we sometimes use rect wires with a reverse curve. This helps to induce proclination in the anterior teeth while achieving relative intrusion. To enhance vertical control, manufacturers provide attachments or bite ramps that function as the anchorage mechanics used in fixed appliances, such as ABPs. This ABP was sent to the lab for fabrication.
I recall that last time, you made it yourself.
But nowadays, we outsource it like this. These structures can be utilized effectively. Next is the expansion of the posterior molars. While alignment techniques are used, how effective are they for posterior region?
Personally, I often feel that the force might still be insufficient in many cases. If definitive expansion is needed, I tend to use appliances like the Schwarz appliance or Marpe more frequently.
That's correct. Clinically, these methods don't always demonstrate a high degree of flexibility. Regardless, these areas might need further development. Now, from the three perspectives I've mentioned, let's examine how these concepts are applied in actual cases. Here, you can see that this patient presents with a Class 3 malocclusion. As shown earlier, movement began with the number 7 tooth. Once it moved about halfway, the number 6 tooth was shifted posteriorly. During this process, there was a reactive force causing the anterior teeth to protrude, so screws were used to counteract this and facilitate posterior movement.
Quite a lot of movement was achieved, wasn't it? Does the patient have to wear the screws? I mean the elastic, not the screw. If they only wear the elastics without using the aligner, it could result in significant adverse reactions.
However, I usually have most adult clear aligner patients. These patients are surprisingly committed to wearing elastics.
For this amount of movement, compared to traditional orthodontic methods, the time frame of around 5 months appears to have been sufficient to achieve the desired results.
That's correct. You might wonder if the movement was achieved solely through the use of screws, but the screws were applied after the number 7 tooth had moved. As you'll see shortly, the posterior movement proceeded sequentially, with the number 7, number 6, and number 5 teeth moving serially. The second aspect is distalization, which, like vertical control, requires careful attention. As shown here, this case involves Class 2, Division 2 malocclusion. There are specific considerations during intrusion in such cases, but we'll delve into those later with Dr. Jungkook's cases. We often use what is called a cutout, but when using clear buttons, I've found that they tend to detach quite easily.
Yes, ready-made clear buttons do seem to have a tendency to come off more frequently.
Following the method I learned from Dr. Jungkook, I used resin and separation rings to attach the setup.
Just to clarify, the ring isn't attached?
No, the ring is attached temporarily before it's removed.
Ah, so it's removed later, right?
Yes, as you can see in the photo on the right, the blue ring was removed to apply the Class 2 elastic. This is a bite ramp, and here we're showcasing a bite ramp from a different manufacturer. This method was applied to this patient as well. In fact, when reviewing the literature, aligners themselves are not particularly unique. The indications for ABP are largely similar. For instance, cases with a slightly smaller angle or where posterior eruption is encouraged can be good indications. As you can see, clear distalization is occurring in the posterior region. This suggests that such movements are feasible. Even though the movements are achievable, there is one notable drawback.
A drawback?
Yes, patients often mention that food gets stuck frequently. Clinicians who are new to aligner treatment are concerned about this complaint. Sometimes, these concerns can lead to conflicts with patients.
This is why setting expectations beforehand is so important.
By informing patients in advance, many of these issues can be mitigated. The third case involves distalization and expansion. As you can see, this was a case where we debated whether surgery would be necessary. Looking at the case, it's clearly Class 3. Skeletally, it is also a skeletal Class 3 case. Despite the complexity, I decided to take the plunge and start with aligner. This is related to what Dr. Jungkook mentioned earlier about Marpe. Personally, in cases where expansion is needed with clear aligners, I often use Marpe. This device is particularly helpful because it can be combined with aligners, and even after cutting off the arms, it still maintains stability. It seems to be a device that pairs well with clear aligners. Similarly, elastic bands are used throughout the treatment. The upper arch also shows significant expansion. Ideally, aligners alone would handle this level of expansion, but achieving that is still quite challenging. For now, auxiliary devices remain essential to achieve the desired outcomes. The fourth aspect involves vertical control and posterior expansion. As you can see, the bite is quite deep, and there is significant crowding as well. Typically, for the anterior teeth, bite ramps are applied from the number 2 to number 2 teeth, similar to ABP. However, in this case, Magic Align provided ramps from the number 3 to number 3 teeth. While this doesn't make a significant difference, there are some considerations to keep in mind. Looking at the photos above and below, can you spot any differences?
Vertical changes do appear to be progressing steadily. Yes, the progress after 4 months looks promising.
As observed, there has been some expansion, though no auxiliary devices were used. The expansion is more noticeable in the premolars than the molars. While stability in the canines is critical, a slight tipping and torque adjustment were utilized to achieve expansion. Similarly, the lower arch has shown some expansion, facilitating alignment in the process.
With this level of expansion and progress, it seems likely that we can move toward the desired outcomes with reasonable predictability.
That's right. We've established 3 key criteria. If these are met, it reinforces the likelihood of achieving successful results. Lastly, as we discussed in the previous session, the more we know, the better we can place orders and respond effectively to prescriptions. Maintaining clear communication with the dental lab is crucial, and understanding these concepts is essential to facilitate that process. This highlights the critical role of communication with the lab. In this context, tips related to the diagnostic process can provide particularly useful insights.
The current trend increasingly involves working with larger labs that handle the manufacturing, which we then incorporate into our treatment plans. As you mentioned, understanding these considerations is essential in ensuring effective collaboration. Let me share some thoughts on predicting effective tooth movements with clear aligners. As mentioned in the previous session, labiolingual tooth movements, particularly those involving in and out adjustments, show promising results. In cases where teeth are misaligned front to back, excluding other complicating factors, clear aligners tend to perform exceptionally well. Of course, if the diagnosis involves asymmetrical crossbite or class 3 malocclusion, the scenario changes entirely. Still, in terms of addressing misalignment and anterior-posterior relationships, aligners seem to yield favorable outcomes. While not definitive, the observed progress is quite encouraging. A similar case can be observed in the maxilla, but focusing on the mandible, this is the progress at 3 months. Here is the appearance after 8 months. If you focus on the mandible, the movements appear to be progressing well. Of course, it can vary from case to case, and I'm showing an example where movement was particularly successful. Generally, however, anterior-posterior movements tend to be manageable with clear aligners. That said, there's a caution to keep in mind when retracting protruding teeth. Take a look at the anterior region. This is quite common. In cases like this, which I didn't treat myself, retracting the front teeth excessively can result in vertical collapse rather than parallel retraction. In the case of the mandibular anterior teeth, they tend to move upward. This is why it's crucial to carefully monitor whether these movements are progressing as intended during clear aligner treatment. It's not enough to simply rely on patients wearing the aligners consistently and assume that everything is proceeding well because anterior-posterior movements seem fine. In many cases, these subtleties are difficult to detect chairside. Often, we only check if the aligners fit well and if the alignment appears satisfactory, which can lead to oversights. Therefore, taking photographs regularly is essential. Additionally, when addressing anterior-posterior movements, I'd like to emphasize that it's essential to monitor vertical changes. Secondly, one of the most common objectives in clear aligner therapy is aligning irregular teeth. This includes both anterior-posterior movements and rotational movements. Regarding rotational movements, there are 4 aspects I'd like to discuss. Firstly, space is necessary for rotation to occur. For rotational movements, the opposing teeth must not interfere with the rotation. Additionally, upgraded aligner materials can enhance rotation, and attachments, when applied, can significantly improve rotational efficiency. These are the 4 key factors I wanted to highlight.
They are key points.
This summary is based on my personal experiences. To clarify, let's look at this case. While it's often said that clear aligners work well, here is the progress at 13 months. Initially, I thought this case would resolve within 6 months. However, this is a case I treated in the past, and as you can see, at 13 months, it still hasn't aligned.
This was done using only pushing forces, without attachments.
So, what comes to mind in such situations? Patients may start to think, clear aligners don't work and they're ineffective. Such skepticism builds distrust in the treatment process. At this point, it's critical to reassess and identify why the movement isn't progressing. In this case, the patient had a deep bite with tight occlusion, which likely caused the mandibular anterior teeth to continuously interfere with movement. For rotational movements, it's important to consider opposing teeth. For instance, lingual surfaces may show wear, and such patients often experience difficulty achieving proper rotation. Mandibular-related considerations are sometimes overlooked in clinical practice, as patients tend to keep their mouths open, and we primarily focus on whether the aligners fit well or if alignment appears correct. Checking opposing teeth and ensuring adequate space is essential. When space is limited, rotations tend to be less effective. This case ultimately resolved, but it took a significant amount of time. To achieve better rotational control, remember to consider the 4 factors discussed earlier. In contrast, here's an example where rotation was achieved within just 2 months. In this case, proper spacing was ensured, and there was no interference from opposing teeth. Additionally, appropriate stripping was performed. Regarding materials, this case was treated using magic aligner, and compared to older aligners, it provides a noticeably firmer grip on the teeth. It's not just magic aligner. Many modern aligners now feature materials that better encapsulate the teeth. This allows the aligner's intended shape to be more effectively transmitted to the teeth, aiding in rotation control. However, challenges remain, particularly with mandibular teeth, which are smaller and less likely to rotate effectively. For instance, in this case, setup process is completed within 2 months. While the aligner design intended to achieve proper alignment, the teeth have yet to respond as expected. In such cases, as mentioned earlier, attaching an attachment to the tooth helped achieve alignment. Of course, other considerations may apply, but to summarize, ensuring adequate space, using effective materials in the aligner, and incorporating attachments are key factors in improving rotation control. These factors collectively contribute to achieving better outcomes in rotation control. While there is much more to discuss on this topic, I'll save further insights for Season 2.
We also have one-day seminars.
But it still has limitations. Please remember this important point about clear aligner. Clear aligners can sometimes cause certain teeth to become intruded, especially during rotation control. When excessive force is applied to teeth that resist rotation, intrusion can occur instead. This is particularly common with central incisors, where height discrepancies can arise. Therefore, it is crucial to monitor these aspects chairside to ensure proper progression and achieve successful treatment outcomes. This patient serves as a typical example of such cases. As you can see, despite managing to achieve this alignment, the patient expressed dissatisfaction. To address this, attachments were added, and further rotations were performed. Specifically, this tooth underwent more distal in movement. However, within just 1 to 2 weeks, vertical problems arose. Such issues are surprisingly common in clinical practice. After making significant progress, encountering such complications within a short period makes correction more challenging. In such cases, we sometimes temporarily attach partial fixed appliances to address the problem. Therefore, it's crucial to consistently monitor for intrusion-related issues during each patient visit. Depending on the situation, I often collaborate with partial orthodontic appliances. In other words, I sometimes combine clear aligners with partial orthodontic treatment to achieve the desired results. This is an example of a case where both partial orthodontics and clear aligners could have been used. However, the patient opted for partial orthodontic treatment. While using partial orthodontics, differences in alignment between the front and back teeth can arise. In such cases, clear aligners can be employed to adjust these discrepancies effectively. That's why I use a collaborative or dual approach.
Combining methods can be a very effective solution.
This is definitely something worth considering. Why did this situation occur? It's not common for teeth to protrude in this manner, but to control the axis, these kinds of counteractive forces tend to appear. So, when it comes to controlling the axis, using a collaborative approach can yield better results. Now, there are cases where patients request corrections because their alignment wasn't fully resolved with clear aligners alone. No matter how much we tried, the issue just wouldn't improve. So I decided to involve using a nickel titanium wire. I've actually uploaded a video about this on the Dental website. The link should be available below, so you can check it out for more details. To explain briefly, for teeth that barely move, say only about 1, 2 degrees or even 5 degrees, you can position a nickel titanium wire. It's okay to add a little bending if necessary. After that, you attach resin to the tooth surface. And make sure to apply Vaseline to the wire itself. The Vaseline is applied to the wire before bonding the resin. It's important to understand this step clearly. The resin essentially acts as a bracket in this scenario. As the Vaseline washes off, the wire is allowed to move back and forth. Once the wire is in position, you bond it securely with the resin, which enables a level of adjustment. So, what does this mean? Well, watching that video might help clarify things further. Here, I'm sharing a clinical tip. Even in clear aligner treatments, for those particularly stubborn teeth that refuse to move, there are various approaches, but this method involves a thin nickel titanium wire. Specifically, this is a 0-1 to nickel titanium wire, which allows for adjustments. This wire can be permanently bent into shape, right? And later, this wire can also be used as a retainer. For more details, I recommend watching the referenced video. It will provide helpful insights. Now, regarding vertical adjustment, it often works very well, but there are cases where it doesn't. In such instances, screws can also be utilized to apply force and pull teeth into the desired position. Finally, let me share one more example. Here we have a patient who came in with rotated anterior teeth. I thought that clear aligners should be able to handle that easily. So, clear aligner treatment was started and continued for about 4 months. After that, the teeth were aligned perfectly. The treatment seems finished. At first glance, it might seem like you could just say, "All done, goodbye." But there are crucial considerations in this case. This patient has a very deep bite, and the mandibular anterior teeth are significantly extruded. Even though we successfully aligned the teeth, maintaining this outcome is critical. However, in this case, the bite is so deep that it's nearly impossible to place a proper retainer. That's why it's crucial not to focus solely on straightening misaligned teeth, but to also check whether the conditions allow for a retainer to be securely placed. For example, in this case, clear aligner treatment was used for 4 months.
Was it applied only to the maxilla?
Well, the mandible was also treated, but you can't only think about the maxilla in such cases. Even if clear aligners were worn for 4 months, removable retainers have to be used for 4 years. It could be the situations that the patient cannot understand. So always ensure to assess whether retainers can be placed securely. Now, let's revisit an earlier point. We might think that intrusion works well, so mandibular treatment was started for 2 months, then 4 months. The maxilla showed significant improvement and alignment, but the mandible showed no progress at all over the 4 months. Typically, you'd expect significant adjustments in about 6 months. Then, you might think that clear aligners don't work and they're ineffective. But please don't jump to that conclusion. While that might be true in some cases, it's important to remember that every case is unique. You must carefully evaluate why the intrusion didn't work in this particular situation. In some cases, if you look at the thickness of the mandibular symphysis of this patient, it's extremely thin. Even with bracket-based orthodontics, achieving intrusion in such cases is challenging. To summarize, when it comes to intrusion, always assess whether the environment is conducive to effective intrusion. The cases shown earlier had thicker bone structures, which made intrusion more feasible, though other factors might also have played a role. If the underlying issue isn't identified, even repeated submissions to the dental lab or clear aligner providers won't solve the problem. Therefore, verifying whether the conditions are suitable for intrusion is crucial. Doing so will greatly help in successfully applying clear aligners in clinical practice.
This is certainly an important factor. Whether it's the maxilla or the mandible, proper diagnosis for intrusion is crucial at the chairside. For the mandible, the degree of constriction in the symphysis bone is a key consideration. The same applies to the maxilla and mandible. The overall angulation of both the maxilla and mandible, especially in cases like Division 2, can make treatment particularly challenging. Intrusion attempts can sometimes lead to root exposure or other complications, emphasizing the critical role of accurate diagnosis.
While there are many factors to consider, I've condensed the easily overlooked aspects to share with you.
So, did you enjoy the discussion? Over the course of these 2 sessions, we've shared insights into clear aligner treatment. While we also host one-day seminars spanning 8 hours, the information provided here is condensed due to time constraints. Whether this serves as a helpful guide or falls short of expectations is for you to determine. However, while clear aligners are undoubtedly an excellent tool, overlooking certain considerations can lead to significant setbacks. Whether at the chairside or during diagnosis, just like with traditional orthodontics, continuous learning and study are essential.
Don't just assume that everything will work out on its own. Instead, actively involve yourself from treatment planning to execution to achieve the best outcomes.
Remember, clear aligners are not a self-driving car. You still need to have a license to drive.
Who knows, maybe in 10 years, fully automated solutions will be available.
It does seem possible. Then, it might be time for us to retire by then.
By that point, you'll be celebrating your 40th year in practice.
We've already reached the 7th episode, and next time, we'll be discussing anterior segmental orthodontics specifically designed for general practitioners. For now, grab a cup of sweet instant coffee to enjoy before diving into your afternoon sessions. Thank you for joining us for this final session on clear aligners.
Thank you for watching.